Hi, I'm Jack Cush, Executive Editor of RheumNow.com, and this is October 7th, 2016, and this is the RheumNow Week in Review. A number of interesting items this week to cover. We tweeted about an interesting report that actually appeared in PNAS on nanoparticle peptide injections that contain inhibitors of NF-kappa B, and in animal models have been used to retard cartilage damage and have an anti-inflammatory effect. The article talked about their potential use in osteoarthritis. It seems like it may have actually wider use, but the idea of nanoparticles being incorporated into the matrix of cartilage that can change the outcomes seems like a sci-fi sort of intervention that would certainly be welcome in certainly a disease like osteoarthritis. So look for more of that in the future. The FDA this week granted breakthrough status for the drug tocilizumab for the use in giant cell arteritis. This is based on some trials that have thus far been reported, and an existing trial that should have complete results reported soon. Breakthrough status with the FDA largely means that there'll be an expedited processing of the indication and application for that drug. So we'll look forward to seeing what happens when the FDA gets the full data on tocilizumab and its use in giant cell arteritis. It's also being investigated in other conditions like polymyalgia rheumatica and other large vessel vasculitis, such as Takayasu's. An interesting report on SNPs being able to predict responsiveness to a TNF inhibitor. Hard to look at SNP research because it's got a large volume and the statistical significance may not be clinically relevant, but there's an IRAK3 SNP, long name RS1541076. It's a polymorphism that, when present, and it's been claimed to have an association with an increased response to TNF inhibitors. So this new report comes from the same authors who've done some of the previous reports, but nonetheless, that is a confirmation sort of report. So I put it out there saying that if you have this SNP, you may have a 1/3 greater odds of a TNF inhibitor response. And currently, we don't really have indicators that tell us who's going to respond well to any one drug. So research like this is welcome. I don't know that this is the final end, but we're going in the right direction when we see it. OMERACT has been busy, as they always are, looking at different ways of assessing disease. They've looked at gout and come up with a way of analyzing outcomes, looking at a disease activity score for gout called the Gout Activity Score, or GAS, not to be confused with my own measure called GAS, which is a global arthritis score, but nonetheless, this measure from OMERACT looks at and validates the use of a score to show how someone is doing. And the score is based on number of flares in the last 12 months, the serum uric acid level, a visual analog scale on a 0 to 10 scale, tender joint count and swollen joint count based on a 0 to 66 joint exam, and gives you a global, a gout activity scale. Do we need this? It's not that hard to tell when someone's active with their gout, but it may be a very useful tool in assessing outcomes in gout trials, and so therefore this is a major advance. Another report comes on the utility of T2T, and we know T2T, or treat to target strategies, do work, but the question is, what's your endpoint? Do you use a DAS endpoint? Do you use a pain endpoint? What's the measure? What if you get really strict and require no synovitis by either MRI or by ultrasound, such as this study? It's called the TASER study, T-A-S-E-R. It's 111 RA patients who were treated in one of two strategies. One, which required no ultrasound evidence of synovitis, and the other was a classic -28 score driven treat to target design. In the end, the ultrasound information did not improve the outcomes of those that were treated with either T2C strategy, suggesting that, as Ronan Kavanaugh said, that he's not likely to be replaced by a machine anytime soon. But this is sort of a confirmational study. It's the same thing was sort of suggested by the recently reported Arctic study, which I think we've covered before. A systematic review of gout and what may happen with blood pressure in gout when you use a urate lowering therapy such as allopurinol suggests that allopurinol independently significantly lowers systolic and diastolic blood pressures and lowers creatinine levels in those who are on such therapy compared to those who are not. This is a major issue. Is allopurinol and hypouricemic therapy going to give you downstream effects, or will it directly affect blood pressure and kidney function? There's growing evidence that urate lowering therapy has a significant impact on blood pressure, and we should be probably more attentive to blood pressure in managing gout patients. But uric acid levels are not good for the kidney. They're not good for the vasculature. A meta-analysis I put up there, an old meta-analysis actually looked at the comparative efficiency of CCP and rheumatoid factor, um, and not surprisingly, we know that CCP is superior to rheumatoid factor, especially with regard to specificity, 96% versus 86% for rheumatoid factor. Sensitivity is about the same for both of them, 67% for CCP and 69% for rheumatoid factor in a large cohort. And a positive likelihood ratio is better with a CCP than with rheumatoid factor. And we also know that CCP does predict erosions much more frequently than does rheumatoid factor itself. So again, rheumatologists do rely on CCP as well as rheumatoid factor in the management of their patients. Um, I threw up a comment on Twitter which said that the ortho literature says surgical excision of rheumatoid nodules is effective. I looked it up because I've seen recently rheumatoid nodules being resected by patients and only seeing sort of ugly outcomes. My experience is it's not effective, shouldn't be advised, and the sad part is we don't have effective therapies to treat rheumatoid nodulosis. And you know, there's weak evidence that B-cell inhibition with rituximab may lessen nodules, but really, from most of the extra-articular manifestations of RA, our best therapies, in fact, are not that effective. But surgery, I wouldn't advise it unless the nodule itself was causing secondary medical problems and/or pain. A recent report came out just today from the MMWR and the CDC suggesting that joint pain and severe joint pain specifically is rising based on NIHS phone surveys of US adults. The frequency of severe joint pain has risen from 10.5 million to 12.7 million from 2002 to 2014. And they give subsets of who's most affected by that, an important point for those involved in public policy and programs to lessen the impact of arthritis. A nice report comes from Cassie Calabrese on our newsfeed this week, where she talks about the arthritis spectrum associated with Lyme disease. As we know, Lyme disease can cause arthritis, usually in acute that becomes chronic, mono or oligoarthritis involving large joints, usually the knee. She reviews that there are other syndromes, including a recently reported one, the other syndrome being a chronic fatigue-like syndrome associated with serologic positivity. It's not clear what that is or if it's even related to Lyme. But she does report a recent report of 30 patients reported from, I think, the Mass General, where they had an autoimmune inflammatory arthritis. Half of those patients had RA-like arthritis. The other half had psoriatic arthritis, mostly, and a few spondyloarthritis patients in there too. The interesting thing is that these people had other joints involved. It was chronic, it was polyarticular, and it often did not have positive Lyme serology. So a new sort of entity that's out there that we should be looking for. Many of us are familiar with ustekinumab, the IL-12/23 inhibitor, and its success in psoriasis and psoriatic arthritis. Recent data about its potential use in ankylosing spondylitis. Well, there are a number of other monoclonal antibodies that are like that in development, but they just are targeting IL-23 and not IL-12. And guselkumab is another one that's just recently reported. A new report in the literature showed that very high-level responses, like it met its primary endpoint. It was better than placebo. It was compared also to adalimumab, and they showed that near complete resolution of skin disease was seen in 72% of those on the IL-23 inhibitor, 50% on adalimumab, and only about 3% on placebo. SIE rates about 2% across the board in all groups. Seems to be a well-developed, a well-tolerated therapy. We'll be seeing more of this in psoriasis and also in psoriatic arthritis. And lastly, the BUILD study, as part of the developmental trials for baricitinib, an upcoming JAK inhibitor. In this particular trial, it was a 24-week trial that looked at ACR20 and X-ray outcomes. The ACR20 outcomes for those on 4 milligrams, I believe, was 62% versus 39% on placebo. There was X-ray benefits with less X-ray progression on baricitinib compared to placebo. This is part of, again, the catalog that baricitinib is developing to take to the FDA this year for a later hearing and later judgment on whether it should be an approved therapy that will then become another JAK inhibitor on the market. That's it for this week on RheumNow.com. You should go to the website to see these citations and read more about these reports. Have a great weekend. We'll see you next week on the Week in Review.